Yes, so good morning all. It's a wonderful day and we take up a wonderful topic on this day. I think the hall is going to fill up as the day advances. So the wonderful topic is CE, that is cluster endophthalmitis, a topic that all want to know of but no one want to talk on, or only few want to talk on. So we have with us an experienced team in the IC, experienced speakers. I welcome my co-instructors. We start the IC with keynote address of Dr. NARENDRAN Muthukrishnan. Dr. Narendran is a practicing VR surgery at Manipal Hospital, Malaysia. He did his MBBS from Kasturba Medical College, Manipal, obtained his ophthalmology specialization from the Royal College of Glasgow, and did retinal fellowship from Sankara Netralaya, Chennai. So you can take the dais, sir. He'll be giving a note on prevention and management of endophthalmitis. Dr. M. Narendran's talk.
Good morning. I'd like to thank the organizing committee for giving me this opportunity to talk. And Dr. Rodney, I apologize. We're going to be overlapping with our topics, but I'll try to keep it very basic so that it makes things easier. I think the wrong presentation.
Dr. Narendran talk. You have loaded, sir?
Yeah, it's loaded.
Okay.
So basically, endophthalmitis is something that we don't want to deal with, but unfortunately, it's a reality when we do enough surgeries that we are going to end up with having a very virulent infection that's going on to go in the eye. There are multiple causes for these infections. Of course, we know one is exogenous and endogenous. Exogenous most commonly is post-operative, followed by traumatic. And of course, you have your acute onset, then you have your cataract surgeries, you have multiple ophthalmic surgeries that can lead to these things. Okay. The percentage of incidence is about 0.03 to 0.7 for cataract surgery. For glaucoma is 0.2 to 1.5. And post-vitrectomy is about 0.05. And intravitreal injections, which we are doing, the numbers are high. Of course, the percentage respectively likewise follows through. Prevention is the most important thing. So we have to look for the risk factors. So if you have patients with blepharitis or eyelid pathologies, and of course, systemic disease, most commonly diabetes, and of course, advanced age where the immune system is a little bit compromised, the risk for endophthalmitis is much higher. And also the intraoperative risk factors like posterior capsule rupture, vitreous loss, and the hands of inexperienced surgeons. I don't mean to be this thing, but then when you have trainees, of course, you have the higher incidence of these things happening. The other source of infection, of course, is from your theaters, where HEPA filters is extremely important. Okay, and then your medications, your solutions that you use, try not to reuse or make it a single use, and of course cleaning of your periocular tissues, irrigation with povidone, and your surgical masks. If they are soiled, sometimes we do tend to have not feel a bit under the weather. We might be coughing and might be using the same mask for reasons. So always good to change your mask if you feel soiled, and having sterile instruments. So prophylactic, what you do is treat the local factors, optimize the systemic conditions. Diabetes is, my target for this thing is I tried anything 10 millimoles and above, I try to avoid doing surgery. Cataract surgery, there's no urgency for the surgery. It can be done at a later stage. Of course, 10 is something that I follow, but each individual, if they have a good control, you can, and have a good internist with you to help you, you can manage them. And preoperative topical antibiotics, I'm not a great fan of that because I don't think so really helps preoperative antibiotics. Airflow design for your theaters is very important, having negative airflow. And then your equipment sterilization and single use of instruments is very important. Now, povidone iodine studies have shown that irrigating the cul-de-sac with 5% povidone and the periocular surface with 10% povidone, it really helps with the incidence, lower the incidence of endophthalmitis. So my policy is I always drop 5% povidone to the cul-de-sac, and then I do the periorbital cleaning, and I leave the povidone there for 3 minutes. It shows 3 to 5 minutes is good enough. So I keep it there for 3 minutes, and then I wipe off the thing. And having a sterile, many places they are using drapes, cloth drapes, which do not have a very sterile environment around the eye. I prefer to use sterile adhesive drapes where you can really isolate the eye from the surrounding areas. And having a good corneal architecture for the wound, self-sealing wounds. And if you do have any doubts about your wounds post-surgical, we always tell our patients we are going to do sutureless surgery. but I think we really need to look at what we are hoping to achieve. If you feel you suspect the wound or there is some form of a micro leak that you are suspecting, putting in a suture is not a big thing. We can always remove after 5 days. A few times I've actually on table, examining the patient about 2 hours after the surgery, I have noticed a micro leak. The choice is between putting a bandage contact lens or taking in to theatre. Of course, the easy way out is a bandage contact lens, but then at the same time, you're not very sure how effective that is. So I always explain to the patient, and I take back to the theatre and put a single suture because it gives you a good night's sleep. At least you have a tight wound. And of course, intracameral antibiotics is extremely important. Okay. Most important is counseling of patients post-operatively. I think that is something that is very important about hand hygiene, installation of drops, teaching the family members, because most of the patients are elderly who have difficulty of holding onto the bottle and trying to drop the eye medication into the eye. So I counsel the patients, I counsel the family members. I actually give them a 3-page instruction, pre and post-operative. It's like an essay. I get them to read. Since I'm coming from a multinational country, so I have it in various languages, Malay, English, Tamil, and Mandarin, so that it's easy something for them to understand and comprehend and to follow. And we give them details about their lifestyle they have to maintain and all that. So the thing is, with Asians, cooking seems to be a very important thing. Doctor, can I cook for my family? So I tell them, yes, you can cook, but you get somebody to cut the chilies and the spices and all that. Chilies, onions and all that, because they want to cook. I allow them to cook, but get the cutting of these all these pungent materials be done by some family members, and they can just do the cooking per se. And clean eye toilet, I tell them to clean the eyes, because I've seen patients coming back for follow-up with the drops dried up on their lashes, and that is a source for possible infection to set in. So I teach them, you boil water, then put cotton balls in this boiling water, let it cool down, and then take out the cotton and gently clean the eyes. So that helps to loosen up these hardened medication particles, which can be easily removed. And most important, when they do present to us, when it's our own case, sometimes it's difficult for us to accept there is an ongoing infection in the eye. When it's a referral case, it's very easy for us to make that diagnosis. But patients will present with blurred vision, red eye, pain, lid edema, and 75%, most of them within first 5 days to 7 days following surgery. So they'll have corneal edema, AC flare, hypopyon, vitritis, scatteral retinal hemorrhages, periphlebitis, loss of red reflex, and capsular plaques. Of course, there are other differentials that you have to think about. Toxic anterior segment syndrome, exacerbation of pre-existing uveitis that could have been missed out, or retained lens matter, usually subincisional, sometimes gets left out if the pupil becomes myose intraoperatively and you just are done with the surgery and you miss out a cortical matter. We have to check on all these things. Okay, so when you do get these patients, history taking is very important. If it's your own case, it's okay, but when you're getting a referral, I think history taking is very important regarding the systemic condition of the patient, whether they're aware of what was any problems during the surgery, whether it's a prolonged surgery. And of course, you go call back the doctor who has referred the patient to you to find out anything that they could help you with. And working up these patients, sometimes we have patients we have seen who are turned to a newly diagnosed diabetic. When you do a dextrose stick, the sugar is about 22, 23, and the patient has no prior knowledge of having diabetes. So that is another thing. You still have to work up the patient as a new patient to work out to see whether they have diabetes, because it could be an undiagnosed diabetic that could be causing this. And of course, an anterior chamber tap and a vitreous tap has to be done, and intravitreal antibiotics. Microbiology, we use the standard methods for the culture plates. Okay, and of course, polymerase chain reaction does help us a lot to make things more positive. And most organisms, as you see, are staph, staphylococcus, streptococcus, and gram-negative organisms. Okay, the antibiotic regime is quite standard. The role of steroids. It does help us with the inflammatory aspect of these infections, of course, but then you need to make sure your gram stain has and your KOHM has no microbiological organisms or fungi, and they do help. And of course, EVS study says that used to say that you do these surgeries for patients who have only vision with PL or worse, but then when you look at it, The early vitrectomy study says that you go in as early as possible to do a complete debulking and to help minimize your tissue damage. So I'll just go through these. Okay. So the end results say that early vitrectomy does help. So this is the algorithm that normally we follow. And I'd just like to highlight a case. This was a teacher, headmistress of a school, who was referred to me by my colleague 1 week post-op. This was the presentation. Her vision was hand movement. And the fundus finding was very hazy view, and B-scan was showing this kind of low refractive opacities. She refused surgery. And of course, you need a consent for the surgery. So I always have an endophthalmitis kit in my clinic. So it's all ready, pre-prepared and everything. So my target is the moment the patient presents, the moment make the diagnosis, within an hour I try to do the tap and the injection. So following the injection, we gave the vision as hand movement, and 2 days later the vision improved to 660, and the gram stain and the GH came back as no organisms. So I was a bit encouraged, so I decided I'll give DEXA along with the intravitreal. I gave the DEXA. 3 days later the vision improved to 6.9. Of course, this is one of those things where I think, and the teacher said, see, I told you, I'm a teacher. I know what works for me. Okay, I mean, not all cases needs to be operated upon, but it's very rare to get these kind of things to have a good outcome. So, like I said, this was a race. I didn't win, but the fact that I didn't fall and break my bones was enough victory for me. So, likewise, in our management for endophthalmitis, we might not be able to save the eye in terms of vision, but if we can stay anatomically, if we can save the eye, I think that goes a long way in the psychological profiling for the patient. Thank you very much.
Thank you, Dr. Narendran, for that keynote, interesting keynote. I would request Dr. Narendran to join us here so that we